This very interesting topic. So, just to begin with, who is active in a pre-hospital setting? Right, okay, it's perfect. It's really good. So, I'm an anesthesiologist. I practice in the Academic Medical Center in Amsterdam, and I have been really interested in pre-hospital care for quite a while. And just so you know, I don't have any conflict of interest because I'm not a paramedic, and I'm not a HEMS physician. So that's actually a real nice position that I'm in, because I can speak freely. So first of all, the persons who were here with my previous talk already seen this slide, but I really would like to thank you for the invitation and return the invitation as well, because we're having quite a similar conference in Amsterdam in January next year. It's called Resuscitationist. I would really cordially invite you to attend this conference in the heart of Amsterdam next year. So, regarding the pre-hospital physician controversy, if you start this subject over coffee, you get a lot of reactions, right? So the first thing that I sometimes hear is, pre-hospital physicians, you know what, there's no evidence, there's no RCT that a doctor can actually make a difference for a patient. And other people say in response, use your common sense, man. We're, transporting patients to the doctor. So if the doctor gets to the patient, that of course will be a good thing. Sometimes I hear, it's my ambulance, my patient. I don't want a doctor getting in my truck. And in response, sometimes I hear, it's the advanced procedures that save life. We really should be getting physicians in the field. Sometimes I hear, you know what? We don't need a physician to do all these procedures. Paramedics can learn how to do RSI. Physicians don't have to go in the field. And in response to that, I also hear, it's not about the tube. So this actually reflects the amount of emotion, really, which is involved in this discussion. And also, if you look to the evidence, it's really controversial. You see studies that show an increase in survival. You have studies that don't show an increase in survival. So then, of course, what we tend to do, if we really want to have the higher standard of evidence, is an RCT, right? So just have a moment and think with me. So we're going to have an RCT on the pre-hospital physician, okay? It's never been done, but we're about to do it. So I noticed that here in Graz, you have a really amazing thing. So the thing is, we have the science tower here. I didn't get to see it yet, but I read it on the internet. So we're going to do an RCT on the pre-hospital physicians. We're going to have like 2,000 people. We'll make it 4,000 people. We're going to throw them off the science tower. And then we're going to randomize, like one group will have only EMS, and one group will receive the care with the EMS and HEMS. For the sake of science, right? This is the science tower. We should be able to do this, right? So this would be like the type of study that you need to do to prove whether or not a pre-hospital physician really makes any impact on the outcome of patients. But of course, we will never have such a study. So if you look at the other types of methods of study that we could use, we could also use like observational studies, right? And it will be perfect, of course, if all the other parameters are really stable, and you have one parameter who is fluctuating, and then see if that makes a difference. So from a scientific point of view, if you would do an observational study, and you do it in a pre-hospital phase, nothing is stable, right? So the pre-hospital setting is stressful. It will have like 200 different factors influencing the outcome of the patient. It's an extremely challenging environment to conduct research in. And also, how do you measure things? You can measure things like when the case is done, but it's better to like measure things when it's actually happening, but how do you do that? It's very, very challenging. Another thing that is really controversial as well is, what do we actually want to know? Do we actually want to know the outcome? Do we actually want to know if a physician really can increase survival? Or is there some other argument or some other type of added value of a pre-hospital physician? So for example, if I just in the afternoon crossed the road to the hotel back and I got hit by a car, and these are both my lower legs, I think I'll have pain. And if you then compare like the analgesia strategy of the EMS compared to EMS plus a pre-hospital physician, for example, an anesthesiologist, I think that would make some impact on the way that I get analgesia, right? So there's no way I'm going to die from this injury, except for the fact that I perhaps get run over by another car, but that's another story. But for this injury specific, I won't die. So it won't make any impact on my outcome if you look at my survival, whether or not there is no physicians, or there are one physician, or there are like 10 physicians, or like with this Congress, a couple of hundred physicians. It won't make any difference to my outcome. So that is why it has been stated that current methods for the evaluation of EMS systems are fundamentally inadequate for answering important questions because they rely mainly on the traditional medical model. And this is a quote from an article regarding EMS systems research, problems of the past, challenges of the future. And I can tell you, this article is from 1995. But the challenges they describe are still very actual to this day. So that's why we decided when thinking about this subject, and I was thinking of like doing some sort of study on the subject because I was really interested. I really wanted to know how these things could be explained with the controversy in the literature and stuff. So we tried to focus on the important question. So I think the most important question, if you think about the controversy regarding pre-hospital physicians, is why? Why would a pre-hospital physician make a difference in the first place? You agree? Okay. So that was actually our first article. So the first article was titled Understanding the Pre-Hospital Physician Controversy, Step 1, Comparing Competencies of the Ambulance Nurses and Pre-Hospital Physicians. So that means we have to know what the level of care is provided by EMS, and we have to know the additional treatment which can be provided by a pre-hospital physician in order to understand the controversy a little bit better. What is the extra thing that the pre-hospital physician brings to the scene which can actually make a difference for the patient? If you don't know this question, you're not going to unravel the controversy. Okay, so just a little sidestep here. I'm just going to show you a couple of pictures of the setting in the Netherlands so you understand our pre-hospital system, because in every European country, and even within a country sometimes, pre-hospital systems can vary very much. So in the Netherlands we have these type of ambulances which are mainly ALS type ambulances. They're staffed with a driver who is like an EMT, like trained assistant for the ambulance nurse. So all the ambulances, all the ALS type ambulances are staffed with a registered nurse with a relevant specialty, so that's either emergency care or ICU or anesthetics, with an additional 9-month period of training. So it's a very highly qualified group of people. And all of our ambulances are staffed with these nurses. We have like national guidelines. We have a national registry for them as well. So that means that there's a lot of high quality stuff going on there. We do have some BLS type ambulances. This is for inter-hospital transport. They're staffed by like basic registered nurses without any specialty. But for emergency care, they don't get dispatched. It's only these ALS type ambulances. So on indication, they can call HEMS. So we have 4 HEMS stations, which are operated by the ANWB, which is quite similar to other countries like Germany and Austria as well. So they're provided with a mobile medical team. So we call them MMT, mobile medical teams. And the team consists of a physician and a nurse. So the nurse of the MMT will have a background either in the ambulance care or in the emergency department. And the physicians who operate in HEMS are all consultant or attending level, mainly anesthesiologists. We got a couple of trauma surgeons as well as HEMS physician, but mainly anesthesiologists. And with the 4 HEMS stations, we cover like the whole country. So we have what they call lifeliners. So we got lifeliner 1 covering the region of Amsterdam, like the whole northwestern part of the country. We got one in Rotterdam, and one in Nijmegen, and one in Groningen. You can see 2 areas in white here. This is operated from Germany, from Duisburg. And this is operated from Aachen. So, and you can see a little area here in Germany, which is green, that is covered by Nijmegen as well, who operates in Germany. So they have a close collaboration in that region, which is really good. Whenever the helicopter is not able to fly, or if it's an incident very close by, they can also be dispatched by a car. The HEMS is dispatched either by primary criteria, so for example based on the call. So whenever a child falls down a window, is unconscious, then HEMS will be dispatched primarily on the call. And when the HEMS is not dispatched based on the call and the EMS arrives and they find a very critically ill patient, then can always secondary ask for HEMS to attend as well. So that's more secondary dispatch. Furthermore, the ambulance nurse is also authorized to cancel the HEMS dispatch. So for example, someone fell down the stairs, they come there at the scene and actually the one is doing fine, then they can cancel HEMS. So regarding the competencies, so this was just a little background on the setting of what we have in the Netherlands. And if you would like to study what the competencies are from the ambulance nurses and the competencies of the HEMS physicians, we thought we should begin with the protocols. Because the protocols actually take care of a majority of different kinds of situations. And so if you want to know what people should be able to do on treatment-wise, then you can look at the protocols. So that's what we did. So here you see an example of the national ambulance protocols. In that edition, we still had the carbon monoxide poisoning, and which actually states like rescue the patient, do the general assessment, provide oxygen, IV access, and depending on the Glasgow coma scale, so you either go transport or consider endotracheal intubation. So from a scientific purpose, if you really want to know what types of skills, what type of competencies the ambulance nurse in the Netherlands has, we analyzed all the protocols and took out all the skills, all the competencies. And there are actually like 3 categories. One category is diagnostic skills. For example, Glasgow coma scale. It's a diagnostic skill. It's a diagnostic competency. You also have therapeutic competencies. For example, giving oxygen and placing an IV. And you also have clinical judgment. So, for example, consider intubation. We went throughout the throughout the whole book, and there were a lot of competencies because there were a lot of protocols. So we took out all the competencies, and we did the same for HEMS, because HEMS has guidelines as well and protocols. So we had the same method for both groups. We also looked at the equipment, because we thought if you carry a vacuum splint as an ambulance nurse, then you probably are competent to use it. That's at least our assumption, right? So we went out through all the equipment, both for the ambulance and the HEMS, and based on the equipment, we also inventoried all the competencies that they should be able to provide in the pre-hospital setting. And finally, we also looked at the registration system. So if you have a registration system that you can tick the boxes, for example, if the patient had a STEMI, if the people had unequal pupils, then we presume that you're able to diagnose a STEMI, if else there would not be a box to tick, right? So we use the protocols, we use the equipment, and we use the standard registration form, both the same for ambulance and HEMS. And that actually results in 2 types of groups. So here you can see, based on the data sources of the ambulance nurses, we got 380 different competencies, different skills, varying from placing an IV, putting on oxygen, Glasgow coma scale, all the things that we talked about. We did the same for HEMS. It resulted in 300 competencies. So now we're almost having a grip on who is able to do what, right? There's one question. We're not sure entirely if we found something in the HEMS protocol, for example. We're not entirely sure that the ambulance nurses are not able to provide that certain competency. For example, in the HEMS protocol, it stated that in head injury, you have to check for unequal pupils, right? Dilated pupil. That will be a diagnostic competency we find in the HEMS data sources. But if we don't find anything on the pupils in the national ambulance guidelines or in their equipment or in their registration, we don't find it over there. So that will mean that we think it's specific for the HEMS physician. But of course, ambulance nurses are competent to check the pupils. So that is why we asked the ambulance nurses to have some feedback on this group and state if they really think that they're not able to provide this specific competencies. And we did the same thing for the HEMS physicians to look at this group as well. So that means that we're trying to have the definitive overlap. So we know for sure that we have a good view on what they're able to do. And this is the result. So we inventoried 500 different competencies, which is really a lot. At least it cost me a lot of work. And the 438 can be provided by both the ambulance nurse and the HEMS physician. And there were 62 which can only be provided by the HEMS physicians. And we're quite certain then that is really specific for the HEMS physician. Why? Because we know for sure that the 62 are not in the ambulance protocols. They don't carry equipment for it. They don't register it on a standard basis. And we got a couple of ambulance nurses really stating to us, yeah, we can't provide these. These are really specific for HEMS physician. So now we get a grip on what the added value is. It's a really useful thing to do. So then we were ready for step 2. So the step 2 was understanding the prehospital physician controversy. Step 2, analysis of on-scene treatment by ambulance nurses and HEMS physicians. In other words, we know on a theoretical basis what the added value is, but how often is that actually being done at the scene? That matters, right? So we didn't know. But first of all, if you want to look at the pre-hospital care and you're going to look at the 62 competencies, then you make the assumption that the other competencies are equally in both groups. And I don't think that is actually the case. So there's actually not only a quantitative difference, but also a qualitative difference. I'll give you an example. So placing an IV. Both of the groups can place an IV. You agree, right? And I think both of the groups really often place IVs. So I don't think there's a real qualitative difference. Might be a little, but not that much. But if you look at endotracheal intubation, and ambulance nurses on average perform 4 to 5 endotracheal intubations per year, and anesthesiologists do that, of course, much more often, then it's very likely that there is not a quantitative difference, but a qualitative difference. So we took this into account. And we looked at a region in the northwest of the country covered by the Lifeline 01 in Amsterdam, and we measured during a 2-month period what happened at the scene. So we got 225 dispatches of HEMS in that period. We got a couple of cancellations. It's like 45%. That's quite high, but then the advantage is that you really get to the cases that you want to go to. Resulting in 129 HEMS dispatches on the scene. There were a couple of outside the study region, and those cases where HEMS really provided care within the study region were 138 patients. So there were a couple of patients in which there was no actual cooperation with ambulance and HEMS. So someone was dead on the scene, or there were the multi-casualty incidents where a couple of patients were already off to the hospital. We excluded those as well, of course. And unfortunately, there were quite some patients that we couldn't be able to get all the data we needed. But we did manage to get all the data of 78 patients. And the data is the run report of the EMS, run report of HEMS, and I did interviews with both the ambulance nurses who were on the scene and the HEMS physician, which are also on the scene. And I asked a couple of questions, and especially when I inventoried all the treatment that was given, I looked at, with the interviews, who've done the certain treatments, and was it something that's really specific for the HEMS physician or not. So we made a couple of categories. The first category is, was the treatment, was the competency really additional? So that's one of the 62 that I mentioned earlier. So that's really specific of the HEMS physician. Or was it a category 2, so it was a mutual competency with a qualitative difference? Or was it category 3, so it's a mutual competency with no qualitative difference? So if a HEMS physician gets at the scene and patient is stable, no critically ill injuries or whatever, and he's like, well, while I'm here anyway, can I do anything for you? Shall I just place an IV while I'm here? Yeah, sure, There's no real added value, right? That could have been done by another ambulance. But the second category is very interesting because we thought, how do we measure it? And we came up with the idea to ask the ambulance nurse if there was anything specific regarding the treatment that the HEMS physician did that they actually asked the HEMS physician to do. So remember the example of the intubation? So if the HEMS physician intubated the patient, for example, a cardiac arrest patient, why did the HEMS physician do it? Was it just practical, and was there no added value? Or was there a specific reason for the ambulance nurse, for example, for previous failed intubations, that they asked the HEMS physician to provide the intubation for them? And if they actually asked specifically the HEMS physician to provide that certain treatment because there was a qualitative difference, because they needed the physician to do it, then we regard it as a category 2. So this is the results. Of all these patients, in total, 45%, they did something additional. So either this is a specific treatment or a mutual competency with a qualitative difference. So you see in total, 33% of the patients, the HEMS physician actually does something which would not have been possible without HEMS presence. We got 21% here, in which the ambulance nurse actually asked specifically to the HEMS physician to do a certain treatment. And we got an overlap in 9%. So it's like almost half. We also asked a very interesting, at least I thought it was very interesting, a question: did you think that the HEMS physician presence was useful? And this is what they replied. There's like, it was of vital importance, really, it was life-saving, or yes, or reasonably, or not really, no, or even counterproductive. I thought, there might be one, I don't know, but or you don't know. So here you see that in general, actually, there's quite some similarity, and it was really interesting because we had a little bit of the picture that that in general the EMS was a little bit more critical than actually these results show. But these are these differences are still interesting, right? So HEMS physicians regard their own presence more often as life-saving. There is some sort of bias in this, I think, still. And there are more ambulance nurses don't think that it is useful that the HEMS physician was there. And what I really wanted to know is when the HEMS physician did something additional, so that means one of the 45%, with the previous diagram, in comparison to the situation where the HEMS physician didn't do anything additional, also not on request, so nothing that we could prove there would be actual additional benefit regarding treatment. How does this relate to the perceived usefulness? And this is the result of that question. So here you see the response of the ambulance nurses, of the HEMS physicians. This is the positive answer to the perceived usefulness. And when the HEMS physician did not provide any additional treatment, still 60% of the ambulance nurses thought the HEMS physician presence was useful. And when they did provide additional treatment, that went up to 90%. And HEMS physicians showed the same thing, but then a little bit higher. That has to do with the bias, I think, might even, which caused the difference. So there are a couple of interesting things. First of all, if you do something additional as a physician on scene, it does increase the perceived usefulness. So it makes sense, right? But this was really a surprise for me, actually. So you have a case when the HEMS physician does not do anything additional. Then 60% of the HEMS of the ambulance nurses still think it was a good thing that they were there. So I think I spoke to all these people. I didn't like inventory it with percentages, but I get a feeling it's a combination of a couple of things. First of all, it's the feeling that when the patient should deteriorate, they're prepared. Second of all, it's the shared decision making. For example, to stop pediatric resuscitation. And also a little bit of expertise thing. If you have doubts whether you like have a good interpretation of the case, you can share some thoughts. And it's also decision making. So for example, if the HEMS physician says, well, we're not going to take the patient to this hospital or take him to the other hospital, that can be an added value of, as well. So that was very interesting. And it's also very interesting what the explanation is of the differences, because of course I said bias. It's a little joke, but not really, because it can be. But the main interesting thing is there a difference in insight? Because there might be. So it might be the case that sometimes the HEMS physician really thinks it's good that I was here because I made this decision that we do this, and I really think that's important for the patient. And the ambulance nurse didn't really catch that decision-making process. But it might as well really be a benefit of for the patient. So in conclusion, regarding the pre-hospital physician controversy, a couple of take-home messages. First of all, there will not be any RCT. I can assure you. But other research methods are useful to look at this process. Second point is added value of pre-hospital physicians is additional treatment, yes, but also other aspects. It's very interesting to take this into account because there was a lot of focus on treatment only. And as last, knowing each other's expertise can optimize collaboration. And this is actually the practical take-home point for you, I think, to get from my lecture, hopefully. Get into dialogue. Discuss cases with each other. Share training. Get out in contact and evaluate cases if you had them. Share your knowledge and expertise with HEMS physicians and EMS. And I'm sure, although I don't have any evidence, but I'm sure that will benefit our patients. Thank you very much.